Hello, my name is Dr. Mercedes Malone, and I'm an internal medicine resident at HCA Florida, North Florida Hospital. My poster presentation is titled Biopsy-Proven Anticoagulant-Related Nephropathy. Let us begin with the case presentation. We had a 64-year-old gentleman present to our hospital with progressively worsening shortness of breath for the past several weeks. His past medical history consisted of well-controlled diabetes and paroxysmal atrial fibrillation. He noted that engaging in simple activities such as licking an envelope or moving furniture caused him significant dyspnea, and he was gasping for air. His family also noticed that he wasn't as he was before. When he came into our hospital, his vital signs were within normal limits, and his physical examination was consistent with lower extremity edema. Laboratory workup illustrated chronic anemia and slight leukocytosis. His creatinine had been trending upwards for a long time now, and a decision was made to perform a urine analysis to determine the underlying etiology behind the upward trend in the creatinine. The urine analysis showed red blood cells and some small amounts of hemoglobin and proteinuria. Chest X-ray and transesophageal echocardiogram did not illustrate any acute findings and were consistent with exams that he had done in the past. There was no new changes on the chest X-ray or the echo. He had been on rivaroxaban for nearly a year for his atrial fibrillation. This was switched to apixaban, a different type of factor Xa inhibitor, after he was found to have some hematochezia. Ever since starting these medications, his creatinine had been steadily increasing, but there was no clear identifiable source. The graph I have here in the center of my poster represents the trend in his creatinine since starting anticoagulant agents. With the red arrow is when it was first started. As you can see, it trended upwards and upwards. A full workup for other etiologies were performed and everything was found to be negative. He didn't have any autoimmune disorders that would trigger kidney dysfunction. He did not have hepatitis B, C. He did not have HIV. So there was no identifiable trigger until graphing his creatinine and noticing that the anticoagulation, when he started that, his creatinine started to trend upwards. So there was a correlation between the use of the anticoagulant agents and his creatinine. A decision was made to perform a kidney biopsy, and it is in the center of my poster here. You can see there are red blood cells within the center of renal tubules. These red blood cells are not supposed to be there, and this is consistent with tubular damage from the anticoagulant agents that he had been taking. Once he stopped taking these agents, his creatinine actually started to improve. My case report aims to highlight that anticoagulation can cause renal disorders, and it is important to consider especially the newer anticoagulant agents such as factor Xa inhibitors as a possible trigger for kidney injury. These agents are typically used in a widespread setting in the hospital and prescribed for several patients. But I believe that their side effects are not well recognized, especially their effects on kidney function. And my case report aims to highlight this important aspect. Thank you, and I hope that my poster was helpful.